It's always a pleasure and a privilege to be at the WCMID and to be able to speak to you all and present. Today we're going to talk about dental caries, obviously. And as a professional disclosure, I'm in private practice 3 days a week in Albany, Oregon. I have a general practice. I also conduct caries research independently. I'm the CEO of Oral Biotech, the manufacturers of Carie Free, and I'm also a banjo player. I'm the lead banjo player for PBR. And here's my cohort, Bill Brown, and I playing at a gig that we had in Hope, Alaska earlier this summer. One of the things I want to start with today is to start with why. And I know that some of you have read this book, and if you haven't, I'd really encourage you to read it. It's one of the best business books that I've read, but it's not really about business. It's really about the core of why you do what you do. And one of the questions that I get pretty frequently that people ask me is, Kim, why do you do that? You know, why are you an expert in dental caries? Why is that an interest to you? And so I want to give you a little background on myself today, just a little back history, share some things about me that you probably don't know. I was born and raised on a farm out of Albany, Oregon, and I would tell you, as a child, I was a curious kid. I was inquisitive. I'm the child that took their toys apart to see how they worked. I really didn't have much interest in playing with them. I just wanted to take them apart, which was a rather probably frustrating experience for my parents who were buying me the toys. But I had that kind of inquisitive mind. I was always looking for a way to make something better. And I got to college, and I learned the scientific method and the value of challenging our traditional thought by coming up with new hypotheses and testing them. And that's how we make progress in our scientific evidence. Then I got to dental school, and I found that I had joined a profession that is very conservative, very slow to change, and doesn't place a high amount of value on people that challenge existing paradigms and tradition. So I think you guys can kind of relate to that. But as I went into practice, I continually, one of the themes in my professional life was that I continued to look for ways to make things better. And that led me to different technologies like lasers or air abrasion. And that led me to minimally invasive dentistry. And 20 years into practice, I was doing all of these things, thinking that we had improved all the processes. And one of the things that still frustrated me was that I was doing everything that I knew to do, and my patients were still getting cavities. And they were doing everything that I was asking them to do, and they were still getting cavities. And I was frustrated, it bothered me, and it frustrated my patients. And I think that a lot of you can kind of relate to that as well. And so about 13 years ago, I made a decision that I wanted to become an expert in this disease because I wanted to be able to be more successful in managing this disease for my patients. And in the process, I learned a lot about this disease that I really didn't know. Coming out of dental school, the way that we were trained when I went to school, we didn't really get a really good background on dental caries. We learned how to create crowns and how to do fillings and do extractions and root canals and dentures. But in terms of managing dental caries as a disease, when I was in school, that was really, I would say, a hole in the system. So that led me to do more investigation and create research. And that led me to here. And I would tell you that dental caries, when I left dental school 34 years ago, I was told that in 30 years, you won't have a job. There won't be dentists anymore because fluoride will have cured dental caries. There won't be cavities. So it's rather surprising to me to be standing here today 34 years later, and not only do we have cavities, but it's the #1 disease worldwide. And so now it's an epidemic that we have a problem with. And I am not okay with that. Like, I believe that's a problem that we as dentists, we as a profession, this is our problem to solve. We're the experts, and I think our patients and our societies are looking toward us to figure out how to solve these issues. And Simon Sinek said, people don't buy what you do, they buy why you do it. And so when I go to work every day, when I come to meetings like this, my desire is to help you, help your patients manage their disease better. Because I'm not okay with it. The way that we were trained to treat dental caries doesn't work. Fluoride has become less effective over the years. We're not going to solve this with a new bonding agent. We're not going to drill and fill our way out of this issue that we've got right at the moment. So it really is, it's really upon us to solve this. And so that's why I'm here today. Dental caries is #1 in the world, and that's not okay with me. And I want to spend the rest of my career doing what I can to make a difference about that. A recent study looked at 291 diseases worldwide. Dental caries is #1 in every country, in every age group within the country. It's the #1 disease worldwide. In the study, they estimated that 35% of all people on the planet today have untreated dental caries in their mouth. And I would tell you the risk for that disease is even higher yet. So while there may be 35% that have untreated decay, there may be 60% that are at risk, and that's not being managed either. So it's the most common disease. Now, when we start to look at pattern recognition, well, why is that? Where did this disease come from? What's causing this today? Why today, 34 years later for me, when I was supposed to not have a job anymore, is there more decay than I've ever seen in my career? And the decay rate in the United States is growing. It's growing in our 0 to 5-year-old children. It's growing in double digits. Every CDC report, every 4 years. So it's getting worse, not better. And why is that? Well, I want to break this down into some, rather going through 50 different complex situations, I want to talk about some common patterns that we might recognize as practitioners. One of the suspects, one of the things that contributes to this disease is bacteria. And typically what I see with patients, they either have too much overall bacterial load or they've got the wrong bacteria behaving badly in their mouth. Another suspect is diet. And certainly I think diet plays a major role globally as well in this disease, but the typical pattern I see in diet is patients either have too much simple sugar in their diet or they're eating too frequently. So if they have a dietary issue, they either have too much sugar or they're eating too frequently. Saliva is a huge issue for us. Saliva is the protective part of the system. And when you take away the balance of the saliva, you get into trouble quickly for patients. And for most patients that don't have enough saliva, and that's typically what we see in that pattern, it's generally medication related. And the last, and this is really more of a recent development, but I have to tell you that genetics appears to play a larger and larger role in dental caries that we weren't previously aware of. And I'm going to share that science with you today, and I think that you'll find it interesting. So that we know that genetically we are predisposed to this disease from a variety of different genes and sources. And so we'll go through those. And at the end of the day, of course, it's the bad guy turns out to be Kaiser Sose, and it's really about pH. Dental caries is a disease of pH. And so as we look at that pattern recognition, we talk about the bacteria. Well, I wrote a paper probably about 6 or 7 years ago, and I identified in the literature, B.C. Nelson and Carson and I published this paper. We identified all the bacteria that had been connected or implicated with dental caries, and there were 27 at the time. I just did this recently because somebody asked me again, and so I went through the scientific literature and we made a list. There are over 50 bacteria now that we know have a causative role in dental caries. So I know that we were all taught, many of us were taught, it was a disease of mutans streptococci and lactobacillus. This disease model, even within the biofilm model, it's a lot more complex than that. The most recent one identified earlier this year was Propionibacteria acidifaciens, and we're going to talk about that study. When we look at diet, one of the challenges we have is Americans eat an average of 22.7 teaspoons of sugar per day. Now, one of the things that I was on the plane coming down here, and I was thinking, you know, I wish I had a little baggie that had 23, essentially 23 teaspoons of sugar in it that I could pour out on the table and say, who would want to volunteer to come up here and eat this? Yet we Americans eat that every day. And one of the other challenges we've got, we introduced high fructose corn syrup because of economics. It's a lot cheaper than cane sugar. And we introduced it into our diet in the United States in 1981. And the curve for obesity and childhood diabetes, all of those curves fit exactly with our consumption of high fructose corn syrup. And so one of my thoughts was, well, maybe high fructose corn syrup is causing this explosion of decay as well. But it's not. Studies have been done on looking specifically at that, and I would tell you high fructose corn syrup is not metabolized in the mouth, it's not metabolized till it gets to the liver. So it doesn't immediately produce acid in the mouth. So it's not that. However, it does contribute to fatty liver disease and hypertension and heart disease and obesity and diabetes. So that is an issue. Americans eat 51 pounds of high fructose corn syrup a year. Mexico, by the way, is number 2. Mexicans eat an average of 32 pounds. So that's an issue. I thought this was very interesting. This came from the Mayo Clinic. It was a large survey. This came out in June of this year. 70% of Americans, and this is all age brackets, 70% of Americans take at least one prescription drug every day. I was shocked at that data. 70% of us are taking at least one prescription drug every day. More than 50% of us take 2 prescription drugs a day, and 20% of us take 5 or more. And I know that in your practice like mine, you see those senior patients that are taking 10, 12, 15. I think the record in my practice, somebody was up to close to 30 different medications they were taking on a daily basis. And the number one side effect of prescription medications is hyposalivation. A better term than xerostomia, because they have saliva, they just don't have enough, is hyposalivation, and it compounds with the more medications that you take. And again, you take that protective saliva out of the system, and suddenly we create a nightmare for ourselves. So one of the challenges that I know that you all deal with your patients is hyposalivation in our senior patients. There are 4 billion prescriptions written in the United States every year for a total of about $320 billion worth of dollars in the drug industry. Those are just, I think, shocking and alarming statistics. And we talked earlier today, Ferocia was talking about, her experience with her physician and a cholesterol. And I mean, this is healthcare today. You go in with a patient with a problem to a physician, and they write you a prescription. Everything is down. There's a drug for everything that you have, and if you have a side effect because you're taking that drug, we've got a drug to take care of that as well. And that's how, instead of asking questions and involving them in maybe wellness, we just give them a prescription. There have been 11 studies now in the past 3 years that have been published looking at genetic causes for dental caries and how they relate to the disease. This is a very interesting case. We'll talk about this study that was Schaefer and Feingold, but they did a genome-wide association study. They looked at a large number of people and 500,000 different gene sites, and they came up with 10 strong associations of individual genes and decay. And one of the things that they identified was there was patterns geographically in the mouth between the genes and the pattern of decay. Like, it wasn't just a matter the patient had 6 cavities. They had 6 cavities, but they only had them on their mandibular incisors. Now, I want you to stop and think for a second. Those are the most protected teeth in the mouth. Have you ever seen a young patient who's only had decay on their mandibular incisors? I'm reading the study and I'm thinking, I don't think those are the last men standing. They're the most protected teeth in the mouth. They're the least at risk. I'm not sure I've ever seen that. So as I'm reading the study back in January, I'm thinking, I'm not sure this is for real, because I can't relate to it clinically. And literally, this patient walked into my door less than 2 weeks later. By the way, that gene is Lysol-2. It's a deficiency of a bacteriolytic enzyme in the saliva, and causes this pattern of the disease. And this young patient, referred to me by a pediatric dentist because they couldn't figure out what was causing. They'd refilled these teeth a number of times, and finally the pediatric dentist said, "Go see Kim. He'll know what to do. He'll know what's causing this." And I look at the mother and I look at the disease, and I say to her, "Your daughter has a Lysol-2 deficiency. It's a genetic disorder." And the mother was shocked, right? And she looked at me and said, "They said you would know exactly what was going on." And had it been 2 weeks earlier, I wouldn't have had a clue. But as I started to read some of these studies, you'll start to identify some of these patterns, because I started photographing them. I'm going to share some of these patterns with you today, because you start to look at it, I start to see it. I wasn't aware that I was looking at a pattern of the disease at the time. You just don't make those associations. But when you know they're there, you start to look for them. And I think it's very interesting. So today I want to talk about an update on the biofilm model of dental caries, to give you the up-to-the-minute science on what this disease looks like from a biofilm model. Then I want to talk about the last year's research and review. In the last 12 months, so from August of 2012 to September 2013, the last 12 months since I did this, what new studies have come out that I think are interesting and important that you should be aware of for dental caries. And then the very last thing I want to talk about today is current topics in dental caries. There's a lot of things that are changing in our landscape in regard to dental caries in our practices. What kind of things do you need to be aware of, and what kind of things what kind of appropriate changes do we need to think about making maybe in our practice? So when we talk about the biofilm model for this disease, we know that there's 3 things about it that we know. It's multiple pathogens, like over 50 now. We know that there are potential systemic effects. The American Academy of Oral Systemic Health is meeting right after this meeting, and I know many of you are going to attend that program as well. We know that periodontal disease has a correlation and relationship to other systemic conditions. Now we've identified that dental caries may as well. And it has hereditary components. When you stop and think about this, it's a biofilm disease. What other biofilm disease do we treat in the mouth? Periodontal disease. Periodontal disease has multiple pathogens, 13 major pathogens that we've identified. We know that it has systemic effects, and we also know that it has genetic factors as well. So it's kind of shouldn't be surprising to us that dental caries as a biofilm disease has those traits in common with another biofilm disease that we also have in the mouth. So if you can kind of correlate those 2 pictures together, I think it'll help you make more sense of this. But one of the things that we know, we start looking at more and more bacteria. Now in this study, they took 8 adults, and they looked at them over a period of 20 weeks, and they looked at the change in the bacteria. And they did a DNA scan on these, and they determined that Rothia dentacariosa, which is, we've long known that bacteria plays a role in dental caries. So that's not new information. But this Scardovia inopata is a new bacteria. And this one was just reported. This study was published last year. So the Scardovia genus of bacteria, it was 2 years ago that Ann Tanner identified Scardovia wigsii in children as being a predominant player, and her study was actually more predominant than mutant streptococci. In fact, in the 40% of the kids in her study that didn't have any mutant streptococci but still had early childhood caries, they virtually all had Scardovia wigsii. So she proposed that it was a very important bacteria in dental caries, particularly in children. And Diane Wolf and her group in Germany, this was earlier this last year, they took 26 individuals, adults that had dental caries. They took 28 caries-free adults. They did a bacterial panel, a checkerboard of 43 different bacteria, and the one bacteria that stood out, it was not present in the caries-free individuals, but was present statistically significantly in all of the individuals that were high risk or had dental caries, was this Propionibacteria acidifaciens. So we continue to add the complexity of this biofilm, and biofilms are very interesting. They're a lot more complex. The ability of these bacteria when they're in a biofilm is a lot more complex than even we thought maybe even a couple of years ago. Now this study came out of Tokyo. They've done a number of studies, but so this one is a few years old. I think this one was published in 2009. They took 300 plaque specimens from people who were undergoing open heart surgery in the hospital in Tokyo. And what they found was when the patient had the bacteria in the mouth, they were looking for what bacteria were present in the plaque, in the heart valve, and in the coronary artery. And what they found was the number one bacteria, when it was found in the mouth, 78% of the time it was found on the heart valve and coronary plaque, was our friend Strep mutans. So, not that mutans streptococci or strep mutans doesn't play a role in dental caries. It does. We've known that for a long time. It may not play as big a role today as we thought that it did 30 years ago, but it is playing a role in bacteremia and endocarditis. So, in fact, the conclusion with this study was that strep mutan and AA may be the causative agents of most bacteremias and endocarditis. So that was number one. One other thing that we know about mutans streptococci is it has a CNM gene which allows it to invade endothelial cells. So these bacteria can actually invade an arterial cell. So now we know the mechanism on how they get there as well. This is one of the first genetic studies that was published. This came out of Pittsburgh, Ozturk. They took 300 random individuals and they looked at their polymorphisms for beta-defensin 1. Now, beta-defensin 1, and there's 3 different polymorphisms. Beta-defensin 1 is a salivary bacteriolytic enzyme. It's a protective antibacterial enzyme found in the saliva. And what they found is that the individuals that had the G20A variation or polymorphism of this gene had 5 times the DMFT scores of the other people in the study. When you get to a DMFT score that's 5 times the other people in the study and the other groups, that's a very significant finding. So their conclusion was obviously people that have this polymorphism for beta-defensin 1, it contributes a genetic role in their risk or their susceptibility to dental caries. One of the next studies that was published looked at 2 genes, the bitterness, the TAS2R38 gene, and the sweet TAS1R2 gene for sweetness, and they looked in children. And they compared the presence and absence of these genes and their decay rate. And what they found was that the children who had this aversion, had the TAS2R38 gene, they're called super tasters. They're extremely sensitive to phenols. These are the children that if you fed them broccoli, asparagus, Brussels sprouts, the child would probably vomit. And I can tell you that from first-hand experience because I can tell you I was a super taster as a child. I could not imagine while my mom and dad and my sister sat and ate this stuff, I couldn't imagine how anybody could eat it. It tasted so foul. And I thought, and I told my parents, God made it taste that bad so we would know not to eat it. And following the time that I vomited it on the table, I was no longer forced to eat those. But the interesting thing about this gene, well, and this paper was published a few years ago, and I called my mom, and it was like, you know, I was not a bad child. I was a super taster. The interesting thing about this gene, it loses its expression somewhere around middle age 40. And I would have to tell you that I'm shocked to be saying this, but my favorite vegetable today is Brussels sprouts. I could eat them every day and not get tired of them. And it's like I couldn't, as a child, I literally couldn't tolerate, I couldn't understand how anybody could eat them, to be honest with you. So we know that those taste genes affect us. Now, my sister she wasn't a super taster. She hardly had any cavities as a child. Me, I preferred sweets. So I avoided the green vegetables. I ate sweets whenever I had the opportunity, and I had a mouthful of cavities. That was my experience as a child growing up. Now, this study was published. They looked at 505 individuals. 212 of those were caries-free, and now we're looking at the matrix metalloproteinases. And those are the enzymes found in dentin that cause the breakdown of the protein matrix in dentin, right? Everybody following me here? And there are a number of them found in dentin. And MMP13 in this study turned out that the carriers that had this and variations of it were significantly at lower risk for dental caries. So it may be that the enzyme, a mutation or a polymorphism of that enzyme affecting that proteinase enzyme that may not as rapidly or easily dissolve the dent and reduces your risk for decay. Well, I mean, you start to think about, okay, so there's taste buds, you start to add up, there's salivary enzymes, you start to add up the broad range of different genes that appear to affect your susceptibility to dental caries. It's very interesting because this makes our disease model quite complex. So we added MMP13 to the list. Now this is the human leukocyte antigen, DQ2. And they found that the adolescents in this study, they had 164 kids in this study from age 15 to 19, and they looked at their DMFT scores. And what they found was that the kids that had this human leukocyte antigen were less likely to have dental caries than the adolescents that didn't have it. So now we're talking about an antigen found on our leukocytes, our white blood cells, right? And if you had this antigen, you were less susceptible to dental caries. And we're not done. Now, I talked earlier about the Lysol 2. This was a huge study, this genome-wide association study that Schaefer and Feingold did and published, and they looked at secondary analysis and data. And I'm going to share all of those studies with you today because it's really interesting stuff. But they found that this Lysol 2 was the strongest association, and it created a pattern of decay just in the mandibular incisors. They also found an association between the AJAP1 gene as well. And they looked at, in this, they had 920 individuals from the age of 18 to 75. They looked at 518,000 gene sites. I mean, we have the computer power now to analyze and compare 500,000 gene sites. I mean, it's impressive when you stop and think about it. Now, what they found was that there was also an association of the mid-dentition and the AJAP1 gene. So looking at people that had just decay primarily on their premolars, right? So there's a pattern of decay. And I got to tell you, again, the same thing. I see adolescents with decay in their molars, but rarely do you see somebody that has just decay in their premolars. So I don't have a really good documented case for this yet, but I'm sure I'm going to find one because I'm sure there's one in my practice somewhere, right? Because it occurs. So again, this other gene appeared, and this this gene was associated. One of the things they did was they described it as actually DMFS1, DMFS2, DMFS3, 4, and 5. DMFS3 then is primarily mandibular posterior teeth. So the DMS3, they found a number of genes that all related and were associated with that genetic pattern of the disease, or that pattern of the expression of the disease. Now, I want you to think again, have you seen a patient that had only decay on their mandibular posterior teeth? You know, I mean, think about it, and the next time that you see it, you can start to identify this may be not just sugar or bacteria or saliva. This may be a genetic condition that we're dealing with. Now, I can't change your DNA. But what I can do is, as long as, if I can identify that there may be a genetic factor going on here, I have to try and outweigh, protect, create enough protective factors to create a healthy balance for that person. But I can't change, but it may be a genetic issue. Now, this was DMS4, and they didn't identify any specific genes with this expression, but there are patients that have decay on only their maxillary incisors. And sure enough, this is one of those. And so you start to look at geographic patterns of decay in the mouth, and I think you'll start to see some of these patterns. And so when I look at a patient like this, it may not just be, and of course what we're starting to identify people that are mouth breathers or may have a constricted airway, and you look at some of those conditions as well, but it may be that we're dealing with a genetic condition. That may be the driving usual suspect for this disease. Everybody follow that? So it's getting more and more interesting. Now, we also found, by looking at the glucose transporter gene, GLUT number 2, they took 80 carie-free individuals from the age of 21 to 32, and they looked at their DMFT scores and found that people that have this glucose transporter gene and the sweet taste genotypes both had an increased risk for dental caries. And I can look at that and I go, yeah, that makes sense to me. But now continue to add on to our list. Now we're talking about glucose transporting in the mouth as well, right? And then this paper was written, this came out, and I'm giving you the backstory to the next study so that it'll make sense to you. But this came out earlier this year, and I think that Takahashi and Nevad in the last 6 years have changed the landscape on dental caries twice already, and they've just changed it again. And just at the point in time, Doug Young and I had published a paper, I think back in October of 2010, and I mean, we were so excited. We had nailed it. We had dental caries absolutely figured out. It was a home run. It was the best paper. We were so excited. And we'd done these DNA studies. We showed how we could modify the biofilm and get these healthy bacteria present, more Strep gordonii and anginosis, and all. We were so excited. And a month later, Takahashi and Nevad published their paper demonstrating that those healthy bacteria that we had identified as we had improved our patients in 30 minutes time in an acidic environment join the party. They adapt, become acidic, and behave, and they're indistinguishable from mutant streptococci. So we celebrated our paper for about a month, and then it was history. The entire playing field changed as a result of that paper. We now know that it doesn't matter which bacteria are present. What really matters is what are they doing, right? So Lizzie Buchan published this in a very respected journal of Nature a couple of years ago. And her proposal is that when we look at a biofilm, we stop thinking about a biofilm being 50 different bacteria living together, and we start to think of the biofilm as one organism. Whether it's periodontal or whether it's dental caries, we start to think about biofilms as being one superorganism, because that's how they behave. Biofilms behave as a single organism. Now that is a profound thought in terms of what we talk about biofilms, because all of this time we've been concerned about who is present in the biofilm, which bacteria are there. We've been trying to identify the bacteria as if that would make the difference. But the difference is what happens. What does that biofilm do? How does it behave? More important than who's there. So Takahashi and Nevad published this paper then earlier this year at the start of March, and proposed that we should stop worrying about which bacteria are present, forget about which bacteria are present. That doesn't matter anymore. What we really need to worry about is what is the output. So instead of looking at which bacteria are present, we should just look at which genes are present. So they did a genome, they look at our genome association abilities, and they're saying we should start looking for genes. And then what's important is not which genes are present, but which genes are being expressed, and what's the metabolic output of those genes, and then what is the biofilm doing as a result of that. So in the case of dental caries, it would be genes that are present in the biofilm that are contributing to an acidogenesis, acid uric environment, creating acid and creating an acidic environment. That's the problem for dental caries. When you have a biofilm in the mouth that's primarily acid uric, you're going to lose mineral out of the teeth and have decay. So that was their proposal. It's like we need to start looking at the genes that are present in the biofilm, not even the bacteria. And that really came from Lizzie Buchan's proposal that we start thinking about this being a superorganism. So rather than worrying about which bacteria are here and doing all this DNA analysis and trying to identify them, which is what I've been doing for the last 12 years, we really just need to look at what's happening in the biofilm. Is it producing acid? Is that the major output that's going on? Because that's what's driving our disease. Does that make sense to everybody? But that's a huge shift in our thinking, because the biofilm scientists, we've absolutely been focused on which bacteria are present. But now we need to really start thinking about which genes are present, because bacteria share genes. And I'm going to show you a study that should raise your eyebrows a little bit later. This study was done and published in October of last year, and they were looking for risk factors as it related to dental caries. They took 1,068 patients from the age of 18 to 75. They took 128 tooth surfaces. So rather than looking at DMFST, they looked at individual surfaces, tried to determine whether they were carious or not. And they noted that there were very distinct risk factors. And they're the same risk factors that John Featherstone has given to us. It wasn't anything new, but it validated, in my mind, the fact that the risk factors that we've been looking at in terms of saliva and diet and snacking, that those risk factors are important. Now, this was the paper that Schaefer and Feingold published last year that came out with the DMFS 1, 2, 3, 4, and 5. And if you'll look at that, number 1 is pit and fissure molar surfaces only had decay in the mouth. Mandibular anterior surfaces, that was the lysal 2 that I talked to you about. Posterior non-pit and fissure, so smooth surfaces in the posterior. Then we had maxillary anterior surfaces, the case I showed you, and then we have the mid-dentition surfaces. So they actually charted out these different expressions of this geographic expressions within the mouth of this disease, these patterns, DMFS 1, 2, 3, 4, and 5. Now, they clustered, it was a genome-wide association. They did a cluster analysis on these 1,068 patients. And again, this is the patient that had the lysal 2 deficiency. Now, I put this study in because this was published in 2004. And at the time that it was published, I used to have it in my lecture because I thought it was very interesting. Because what they did in this study, they looked at 20,000 school children aged 5 to 10. It was a 10 multi-site study, and they followed them for 4 years. And what they determined in the study was that there's a risk, a geographic risk individually for a tooth, for dental caries, based on where it's at. And what they found was that the number 1 risk was the occlusal fissures, lingual and buccal, and occlusal fissures of the first molars. Well, I mean, no big surprise there. And the least risk were the mandibular canines. And I looked at this and I thought it was really interesting, but I really didn't know what to make of it. Now, in light of Schaefer and Feingold's work, I think these things correlate. I think what they were identifying early on, that there was a risk for a tooth based on where it was at in the mouth, may actually have some genetic expression for that disease, for that pattern. Does that make sense? I think the two are related. But the study, aside from being interesting, never really made sense to me. I didn't know what to make of it until Schaefer and Feingold published their paper this last year. Now, this study looked at erosion, and they took 39 adults, 17 of them were caries-free, and they just measured pH. And they had them rinse with drink orange juice. And they looked at the pH following that, and what they found was that the people that had less saliva and that had poor buffering capacity or had lower pH of their saliva to begin with had a lower drop in pH, or should we say a more significant drop in pH, and it stayed at that low pH for a longer period of time. Increased their risk for decay. This is what you'd expect to find. But I thought that it was interesting that yes, buffering capacity, pH, drinking something like orange juice. So if you've got somebody who has dental erosion, that's somebody that's more susceptible. It may be that they don't have buffering capacity of their saliva. They may be predisposed, and that may be a genetic condition before we get done with this, but they're more predisposed. So for somebody like that, giving them more orange juice to drink every day may not be a good idea. It may increase their erosion. Now, when do you brush your teeth? This is very interesting. This is in the Wall Street Journal earlier this week, and I have to tell you that they talked to a past president of the AGD. They interviewed him about this, but he didn't really answer the question. But the question was, when should you brush your teeth? Because there was a study that was recently published that said you should not brush your teeth right after you eat. You should brush your teeth before you eat. Because if you take a patient, and you're going to see this, and if you see this patient with this erosion in the mouth, I want you to think about this. If you take a patient that has erosion, they have less saliva, they have less buffering capacity, and they eat something really acidic, maybe a grapefruit or orange juice in the morning, and then they brush their teeth and they're brushing with a really abrasive toothpaste, You've softened the enamel with that citric acid, and now you're brushing the enamel away. And I've seen patients that literally didn't have any enamel left on their teeth. They like brushed their enamel away. And I for the life of me, couldn't figure out what was going on. But I think the connection here is brushing their teeth after they soften. And what happens when that pH drops when you're eating, it doesn't matter what you eat, when the pH drops when you eat, the calcium phosphate is trapped in the pellicle. And if you then go brush that pellicle away with a very acidic toothpaste, it's gone. The calcium phosphate is gone, and you've got a net loss of mineral out of the tooth by doing that. So that's really a reversal of our thinking of our patients. Our patients, if you told them brush before you eat, they're going to look at you like you're crazy. I'm going to eat, and then I want to go have clean teeth. I want to brush them before I go out or do this or that. So I think that's a really important thing that we can share with our patients. But I thought that was interesting. Now the next two studies I want to share with you contradict each other. And that's one of the reasons I want to share them with you. This was a systematic review looking at the risk of asthma in children and dental caries. Now, they looked at 11 of the studies were included were on primary teeth, 15 of the studies were on permanent teeth, and one of the questions becomes, they had an increased risk, doubled the risk for dental caries in these, basically in the systematic review. Now, why would that be? Why would asthma increase? It's the number 2 disease in children, by the way. Now, dental caries is number 1. Number 2 is asthma. Why would asthma increase the risk for dental caries? Well, they're using an epihaler, right? A strong antihistamine. What does an antihistamine do? Stops fluid, right? Stops salivary flow. You reduce the saliva in these kids, and you're going to put them at greater risk. Now, that makes sense to me. If you've got a kid that's got asthma, that's probably they've got an increased risk for dental caries. Excuse me. And then I read the next paper, where they looked at children an average of 6 years old, basically, compared them with healthy kids, and found the kids that had asthma had lower DMFT scores. That the asthma reduced their risk for dental caries. But that was the results found in this study. So the previous one was a systematic review. This was an individual study, cohort study. So it's like, I don't know what to make of it other than to share with you I'm fair and balanced. I'm going to show you the positive and the negative, and they may conflict, and we're going to have to make a decision. Which of these two studies do you think clinically makes more sense to you? Would you be willing to apply? Now, this was a very interesting study. Attention deficit. Oh, Scott, look at that. Oh, never mind. ADHD, attention deficit and hyperactivity disease. So they looked at, they had 31 children that had ADHD that were untreated. They had 30 kids in the study that had ADHD that were on medication. And then they had 30 kids that were the control unit that didn't have ADHD. And what they found was that basically they were no different than the children that were the healthy control. And one of the questions that they might have less salivation, and it could be because of Ritalin or some other medication they might be taking to control that. But again, they had the same appearance from a DMFST score, and looking at them, they were no different than the healthy controls. But they proposed that they might be at a higher risk because of the fact that they have less saliva, might have less saliva. So ADHD, this study, there were 1,830 children. They were basically 5 years old. And what they found was that at 12 years of age, the greatest predictor for decay in permanent teeth at age 12 was having decay at age 6. So the greatest predictor of future disease was present disease at age 6. So they looked at them, basically followed them over this period of time. And they found also that 30% of the disease was pretty much found in 30% of the population. Most of the disease was found primarily in 30% of the kids. And I think that we see that within the population. There's a group within our population, particularly of children, that are most at risk for this disease. Although it crosses all social boundaries. When we look at poverty has been proposed as a risk factor for dental caries, particularly in children. And we know that 1 in 4 children under the age of 3 to 9 are living below the poverty level in the United States. That has not changed in the last 6 years. I was reading that in the newspaper this morning. And a significant percentage of those have untreated dental caries. And we know that older adults living below the poverty level, 34% of them are edentulous, which is probably an improvement. When I was first out of dental school, probably half of the patients, older adults, were edentulous, or maybe even 60 or 70% were edentulous. I think we as a profession have gotten better at saving teeth for seniors. Now we're struggling with how do we keep them from getting decay in those teeth as they have less and less saliva. In this study that was published this last year in November, they looked for salivary biomarkers. Now this has been one of my kind of hot topics for a number of years, trying to look at, are there biomarkers in the saliva that we can identify specifically. Now you all know that I use ATP, and we use that as a biomarker for this disease, and we pull that from the biofilm on the teeth. But these studies looked at, are there biomarkers in the saliva that correlate to dental caries? There were 188, it's a systematic review. There were 188 papers they examined. They included 7 in the study, and 3 of them they found a biomarker for, but based on the overall weight of the studies, it wasn't significant. So they couldn't make a determination that there is a biomarker for dental caries yet in the saliva. Now, will we find one? I mean, there's a couple of thousand biomarkers found in the saliva, so protein. So it's like, will we find one? I think that's a possibility for us somewhere down the road. Certainly, work is being done right at the moment on salivary biomarkers for breast cancer, colon cancer, pancreatic cancer, some pretty serious diseases. So we may have an opportunity to help people with that. In this study, they looked at the decay rate based on, or the risk rather, for decay in children. This was Hispanic children, using the American Academy of Pediatric Dentistry's caries assessment test, their CAT test. They compared it to just cultures of mutans streptococci. And what they found was the cultures of mutans streptococci were more predictive of actual caries experience in these children than the AAPD's risk assessment form. So I've shared with you there are a number of risk assessment forms available to you. This is one of them. You can take that information, the data, and the results of the study and make decisions for yourself based on that data. John Featherstone did a very interesting study in his group at UCSF. They took 230 adults. They followed them over a 2-year period of time. They gave them chlorhexidine rinse for a week. These were high-risk adults. Chlorhexidine rinse for a week, fluoride, 0.05% fluoride rinse for 3 weeks, and then they measured the mutans streptococci, the lactobacillus, and the fluoride level in the saliva over the patients over a span of 2 years. And what they found was it had a really good effect on the mutans streptococci, had lesser effect on the lactobacillus. The fluoride levels weren't really different on. They were using 1,100 part per million fluoride toothpaste at the same time. There wasn't really a huge difference. What they did find was that the people in the test group had a 24% reduction in their DMFT scores. So while that wasn't a home run, they didn't cure dental caries, at the same point in time, getting a 24% reduction in decay is significant. And so it demonstrated that we can change or alter the balance in the mouth by using some of these therapies. And so it gave us, I think a validation or a foundation to say, yes, we can do this. We can change the biofilm. We can change your risk for decay implementing some of these therapies. Now, one of the challenges that we have is we didn't target that therapy. It was kind of the shotgun therapy. Everybody was high risk for dental caries. Didn't matter whether they had a dietary issue or bacterial issue or a salivary issue or genetic issue. We just gave them all the one-size-fits-all treatment, and so we got a 24% reduction in decay. Are people following me here? Some of those patients, if they didn't have a high bacterial load, wouldn't have had any benefit from the chlorhexidine. There wouldn't be any benefit because that wasn't their problem. It may have been that they had a dietary issue. It may have been they didn't have enough saliva. So we need to be able in our research, if we're going to get more effective at treating this disease and get better outcomes in our studies, we need to be able to target that. Like in this study, they would have been better if they could have targeted and just picked the patients that were high risk because they had a high bacterial load issue, put them on the chlorhexidine, and they probably would have seen a better outcome. Does that make sense? So those are I mean, that's one of the challenges that we have in terms of our scientific evidence. This is a study that I did with John Kois and Graham Milicic and Yada this last year. We started working with nanoparticles of hydroxyapatite mineral to see how it would affect remineralization on enamel. We created some artificial lesions. We applied the gel one time for 24-hour exposure in saliva, and then we looked at it and found that in fact it did attach to the surface, and it increased the fluoride levels on the enamel as well. So we published that in Compendium in March of this last year. In this study, they looked at 150 kids. 146 of those were the controls, and they gave them, these were basically school children or preschool children between the age of 2.5 and 3.5, and they were all using a regular fluoride toothpaste, an 1100 part per million fluoride toothpaste, and in the test group, they also got to use a 10% CPP ACP paste, which you guys can all identify what that paste might have been. And what they determined in the outcome was that it didn't make any difference at all. Adding the CPP ACP had no difference in net effect over the standard 1100 part per million fluoride. I thought, you know, there's always the question of how does this work? Does it work? Does remineralization work? What's the net outcome? And I think that's a challenge. Again, it may be a function of us not being able to target our therapies. This study looked at Prevident, fluoride, and MI Paste Plus for white spot lesions. And what the patients did, they took 115 adults. They had 34 in the MI Paste group, 40 in the fluoride varnish group, and they had 41 in the control group. They applied the medicament every night for 8 weeks, and then they looked at the outcome and found there was no difference in outcome whatsoever. So I know that Prevident, or a fluoride 5,000 part million fluoride gel, or a CPP ACP paste have been promoted to eliminate white spot lesions. And what they found, I think there's two problems with this study. Number one, it was only 8 weeks. And this is a process that probably more realistically would take 8 months to 8 years. It's a months to years, not a week phenomenon in terms of an outcome. And one of the things that we know based on the histology of the enamel, it remineralizes from the outside in. You can't remineralize enamel from the inside out. Crystals, it'd be the only crystal in the universe that behave that way. It behaves like all other crystals. It's by oriented attachment of nanoparticles. That's how all crystals grow. And enamel behaves the same way. It remineralizes from the outside in, and so the problem is you can remineralize about 100 microns deep. The studies are consistent with this. It's about 100 microns in, and then it really stops. You get some internal transfer and some remineralization deeper in the lesion, but it doesn't happen from the inside out. There's no way to make that happen. As soon as it contacts, it starts to fill in the defect from the outside. So if you remineralize a white spot lesion and it disappears, what do you know about how deep that white spot lesion was? It was 100 microns. Right, exactly. So it will work, but the problem is most white spot lesions are probably deeper than 100 microns. So we don't see an effect on that. So that's a challenge for us. Better to prevent the white spot lesion than have to try and deal with it after the fact, particularly on patients that have had orthodontics and bonded brackets. In this study, this was just a review looking at antibacterial effects, a laboratory study looking at fluoride, and found that it actually inhibits biofilm formation as well as having an effect on the dental hard tissues. So fluoride, and of course this is not new either, we have proposed for a long time that fluoride inhibits bacterial activity. And so it also inhibits biofilm formation on the teeth. So fluoride has a lot of benefits. The problem is, at this point in time, with the disease we're trying to treat, fluoride by itself, because maybe that's not it's not targeted to the exact problem the patient has, isn't providing the effect that it did a long time ago. In this study, looked at children again with fluoride varnish, and they looked at, actually it's a kind of an interesting study because they took 198 kids with fluoride varnish and they took 181 that they looked at a control, and what they found was that fluoride varnish actually reduced the DMFT and the decay in molar pit and fissures. Traditionally, we have thought that fluoride didn't really improve the decay or demineralization or lesions on it was great on smooth surfaces, but not on pits and fissures. And this study indicated it significantly reduced the DMFS on the increments, and particularly on first molars, which is what they studied in the pits and fissures. So I thought that was I thought that was an interesting result that I should share. This study was a report that came out of Australia, and one of the questions was, does the benefit of fluoride in the water, is it something that you had to have from the time that you were born, or is there a benefit if you were 60 and then they fluoridated the water? Is there any benefit for fluoride in the water for somebody whose teeth have already completely developed? And so what they looked at in an Australian society, they took patients that were born prior to 1960, and they took patients that were born after 1960, and they looked at, because that's when they fluoridated most of the public water in Australia, and they looked at what's the difference in the decay rate between these two groups, the DMFT scores, and found actually that the group that was born before fluoridation, so their teeth were already developed primarily when they fluoridated the water, actually had it's just a slightly higher, but not significantly, had just a slightly higher. It was 11% versus 10% DMFT. So there is a benefit regardless of what age you are, or what development your teeth, what stage your teeth are in terms of development, by having fluoride in the water. The CDC estimates in the United States that fluoridated water reduces the overall decay rate by about 27% per year. I'm not really sure how they come to that conclusion of the data, but I think that certainly that there's enough data there that there is a benefit from having fluoride in the water. In terms of outcome, how that evolutionarily modifies the behavior of the biofilm, how the bacteria adapt to 1 part per million of fluoride in the water over a 40 or 60 year period of time, I don't think we know. But I was reading another study that was just published from the CDC looking at the bacteria that we have now that are resistant to all known drugs. There's a growing list of bacteria now that are resistant to all known antibiotics. And are these bacteria going to learn how to evolve and adapt around fluoride as bacteria are evolving and adapting around other antibiotics? And there are not a lot of new antibiotics. Those are very expensive to create. There are not a lot of those on the horizon for us. So they estimate that's going to be a huge problem for us in the next 25, 30 years. Now, this was a group of Aboriginal children. There were 534 in the study. They were aged 3 to 5, and they applied fluoride varnish. What they found was that the fluoride varnish reduced the DMFT scores on these kids. Now, you're talking about primary teeth. They're 3 to 5 years of age. What they found was that it had the greatest effect on teeth that didn't already have decay. So if you sealed, or not sealed, but put fluoride varnish on a sound surface, that had a better effect in terms of outcome than a tooth that already had decay that we put fluoride varnish on. Huge shock waves through the audience, but that was the result. This study, they looked at the difference between resin-modified glass ionomers, real difference between the two in terms of outcome. Although 2 of the 6 studies showed that the resin-modified glass ionomer did have a somewhat more caries benefit than just resin composites. So I know that, one of the questions we all have is, should we use glass ionomer for our sealant material? Should we use resin, pit and fissure sealant material? They're both going to be successful. They're going to have different modes of failure. The glass ionomers are going to bulk fracture out of the pit and fissure, but there probably won't be any decay. The pit and fissure is going to leak and fail because of decay. So it's, if you lose your seal on the resin pit and fissure sealant, it's going to fail because probably of leakage and decay. Whereas a glass ionomer, in my experience, is they bulk fracture fail, but there's no decay underneath them. That's because of the fluoride and the transfer within that material. And one would be Yeah, I mean, you're really talking about an adhesive failure on both, Scott, and one is um, and there actually could be a cohesive failure within the glass ionomer because it breaks off and may leave some material on the surface. And actually, what we've got with the resin uh, pit and fissure sealant is an adhesive failure at the surface of the resin, and then you get leakage. So it's an outcome. The outcomes are different. I mean, the failure mode is different. The outcome is different. May or may not be. I think we've all had the experience. I mean, I think we've all had a catastrophic failure with a pit and fissure sealant or resin where it failed and you're doing a root canal on a teenager. I mean, I think we've all experienced that. And so and that gets back to the whole how we look at evidence base. Scientists and our regulatory bodies and our associations make recommendations based on population studies, right? And they say, well, it has this percentage of success. And you and I are looking at a longitudinal study on an individual. Basically, I'm looking at this one person and what's going to happen in the next 20 years, because if I have a failure there, it could be catastrophic. So I may look at this different than somebody may recommend pit and fissure sealants because they have this percentage of success better than glass ionomer, but I'm looking at it longitudinally rather than population-wide. Does that make sense? Yeah. I'm not sure I'm going to tell my patient that I'm going to put in a sacrificial anode on your tooth, but but it's a great analogy. In this study, they looked at 501 children at an average age of about 9 years of age, and they compared a resin sealant just placed one time, 5% fluoride varnish that was placed twice a year. Then they looked at a 38% silver diamine fluoride solution that was placed once a year, and a placebo control. And what they found was that there really wasn't a lot of difference. The sodium fluoride varnish, placed twice a year, was as effective at reducing decay in the fissure as a pit and fissure sealant. So we've got a second study saying that. And the silver diamine fluoride, and the same thing would happen probably with silver nitrate. Neither of those materials are approved by the FDA for our application in dentistry in the United States currently, but we could certainly we have silver nitrate available to us off-label, and we can use that. But again, the point I wanted to make from this study that I thought was interesting was very traditionally we've thought that fluoride varnish wouldn't have an effect in a pit and fissure, and appears to be as effective as a pit and fissure sealant. So I thought, I mean, that's a significant finding, I believe. Does that mean we're not going to do pit and fissure? We're going to do fluoride varnish instead of pit and fissure sealants? I don't know. It may be a decision that we come to at some point in time. So anyway, I wanted to share that with you. This was again a systematic review, and this has been a hot topic in dentistry. And there's a lot of the practice-based network research that some of the networks have been reporting and studying this as well. There have been a number of people looking at this. If you've got a deep carious lesion, should you remove all of the decay, or should you remove most of the decay, leave a little, place some material over it, and then bond over that? Do you have a better outcome by reducing your risk of exposing the pulp by leaving a little even infected dentin in place versus taking it all out? And the science is a little muddled depending upon which study that you read, but in general I would tell you most of the studies are leaning toward you're better off to leave decay behind and place some material over it, whether that's a glass ionomer or MTA or whatever material you're going to place, and then bond and seal over the top of that than you are to take it all out. You increase the outcome or for a need for a root canal by removing all the decay versus leaving that last little bit. When you start to get nervous and you're thinking maybe this filling is going to turn into a root canal appointment, maybe I should stop and leave that there. And I've been doing that now for the last couple of years, and actually would have to report to you that I've had very good success with that. So in terms of outcomes. So this is one. This is a hot topic, and it's controversial. I mean, I would tell you there are strong opinions probably on both sides. I read that informed consent long discussion, and I stayed out of that. I stayed out of the crossfire on that. What was your question? what I'm putting over the top, you should either use MTA or what I've been using is Unisem cement, about a millimeter of Unisem. It creates a pretty good, around the periphery of that where you have sound dentin, it creates a pretty good biological and chemical barrier. So that's what I've been doing. Then Stan brings up a really good question. Then informed consent, what do you tell your patient? Well, I tell the patient that I did this intentionally so that you know that it's there, because I believe that it reduces your risk for needing a root canal. And I've had good clinical success with that, which is part of evidence-based dentistry, is my knowledge and clinical expertise and experience. So, but I think obviously you can envision a situation where you have the patient, you do that, the patient leaves your practice, goes to somebody else's practice, now needs a root canal, the doctor opens up the tooth, finds decay underneath your restoration and says, oh, Dr. Kutsch didn't remove all the decay, that's why you need a root canal. You know, and I mean, you could see that happening. I could see having a conversation with the board over a case like that, but there's certainly scientific evidence to support your decision to do that. Moving right along, this study this last year created more email response and more questions for me than any study I've seen in the last 15 years on dental caries. And this is the study, Bader and Sugars. And I have to tell you, these guys I respect them a lot. They're good researchers. This was a well-done study. And they took 691 adults from the age of, I think they were 18 to 75. It was a multi-site, 3-site study. They followed them over 33 months. They were all high risk for dental caries. And they gave them, all they did for treatment, all they did was gave them 5 lozenges or mints of xylitol a day for 33 months. And what they found was that at the end, there was no difference in the control group as there was in the group using the 5 xylitol mints. Well, that's what I would expect the result to be. But you had immediately the New York Times, you had everybody that was against xylitol came out and said, aha, xylitol does not work. We told you it doesn't work. In spite of the fact that there's a tremendous amount of scientific evidence that xylitol is a very good anti-caries agent. I could spend the entire time just sharing those studies with you. But it was a very good designed study. The problem, again, gets back to there may be people that we didn't target that therapy. It was just 691 people that were all high risk for dental caries. And whether we gave them chlorhexidine or we gave them xylitol or we gave them 5,000 part per million fluoride or gave them MI paste or whatever we gave them, if you just gave everybody the same thing, you're not going to get a great treatment outcome because it isn't a targeted therapy. Because there are different risk factors. We need to target the risk. And we need to move our scientific investigation away from these large studies like that and start targeting the individuals. This paper was published by Philip Marsh back in 2009. I include it because I think it's important. When we first started talking about pH and this disease and maybe pH as being a therapeutic strategy 12 years ago, people laughed at us. And people aren't laughing anymore. In fact, more and more researchers now are talking about, in fact, I'm even seeing advertisements on television of toothpaste companies talking about neutralizing the mouth. That wouldn't have happened if we hadn't been driving this point home. Now, this is something I want to share with you may not be aware of. I had a hygienist. I was at the Denver midwinter meeting in January in Denver, speaking in it, and we were talking about pH and what you should drink, what you shouldn't drink, and going through a risk assessment form and talking about all that. And I had a hygienist ask, Dr. Kutsch, do you know what the pH of bottled water is? And I have to confess, I don't know. I'm assuming it's 7. Tap water is 7, 7.15, depending upon where you live, but it's right at neutral. It's water. Water is neutral. That's the middle of the scale. And I was shocked and alarmed to go to the internet, and she said, I think you need to go Google and start looking at the pH of bottled water because about half the bottled waters have a pH of 4.0. And Michelle Obama right now, her big thing is to promote water. Americans need to drink more water. Americans do need to drink more water. Go to the tap. The message is there. This is something I didn't understand. They're promoting the White House is promoting 14 brands of water that people should drink. I'm not sure I follow where the White House is suddenly promoting individual products. Like, we're recommending these 14 brands of water for you to drink. But I'm sure that that has something to do with lobbyists and money. But anyway, I was shocked by that. You know, it was like we were going to recommend these 14 specific brands. Maybe she's recommending the 14 brands that all have, I'm hoping that they're aware of the pH, and she's recommending brands that have a pH of 7 or above. But when you tell your patient, and I would always tell patients, if you can't do anything else, rinse your mouth out with water. Well, if the water is 4.0, you just rinse it out with Diet Coke or regular Coke or orange juice, right? So it's like we're thinking we're doing something protective, and it may not be protective. And I had actually had one dentist contact me who couldn't identify his risk factors. He continued to get decay, a dentist, and was struggling with the fact that I'm doing everything right. And yet I'm continuing to get a lesion here and there. And I don't know what's going on. And I said, tell me what you drink during the day. Well, I drink water. I drink water all day long. I'm healthy. I'm a health nut. And I said, well, what kind of, do you drink in tap water? Oh, no, I drink bottled water. Well, do you know what the pH of the bottled water you're drinking is? No, he was sipping water all day long that had a pH of 4.0. And that was the one risk factor that we identified. That's the only risk factor. But I got to tell you, that could create an acidogenic, acid uric behaving biofilm. They have to behave that way to survive in that environment. So the question is, why would bottled water have a pH of 4.0? And I can tell you why. They acidify it for shelf life purposes. Okay? And if it's carbonated water, it has carbonic acid on it, and it has the same pH as any soda. Soda water, whether it's water or Diet Mountain Dew, have the same pH. Everybody okay with that? Correct. Yep. I don't know about that. I don't know about that, Stan, but I know. I'm just showing you data, and there are a number of sites. If you go to the internet, you'll find a number of sites that have independently done this and documented the pH of water. So when I tell a patient now to go drink water, if you're drinking bottled water, go to this site, look it up, make sure you're drinking a brand of bottled water that is 7 or above, or you just will be drinking something acidic. Could be. Could be. But, I mean, if we're trying to recommend the water as a protective, healthy thing to do throughout the day, and they're drinking acidic water, they just will be drinking coffee or tea. Now, you and I could have a soda, John. You can have a soda once a day or twice. You can drink soda, and if you're healthy and you have enough saliva, you can probably get away with, and you've got an effective diet, and you've got good home care, and you can do all that, you've got a lot of protective factors, you can get away with it. But for the patient that doesn't have that in place, the senior citizen that's already xerostomach, that's a nightmare, okay? I mean, they're more susceptible, so it really depends on their susceptibility. One of the things that we know that is that there are bacteria in the mouth that actually increase the pH after we eat. There are bacteria in the biofilm that actually break down the urea into ammonia, and that raises the pH. So alkaline pH reduces your risk for dental caries. Now, one of the questions I continue to get over the last few years is, does breastfeeding have an effect on early childhood caries? And there's a lot of sugar in mother's milk, right? In lactate. And so you look at it and go, well, so this study, they looked at 207 mothers. They had 146 babies that were exclusively breastfed. They had 38 that were partially breastfed, and then they had 23 that were exclusively formula fed. And what they found, actually, this is quite interesting, the babies that were breastfed had a healthier and less diverse oral biofilm, microbiota, than the children that were drinking formula. And they hypothesize it may be from suppression from the lactobacillus that's in mother's milk, may actually suppress other bacteria from invading the mouth at an early age, an early window of infectivity. So it could be that Mother Nature is still best. It could be that, but it could be, you stop and think about it. Do we think that we can create something that's better than mother's milk for an infant? I mean, come on. So anyway, now, however, if the baby is breastfeeding at will, like if they're getting to nurse every 30 minutes, now that's a problem. And that's a problem whether it's formula or breastfeeding or whatever, but just to breastfeed a child doesn't have any effect. And there was no evidence in this study, this was in JADA, connecting breastfeeding and early childhood caries. So there's no correlation there. So if you have young mothers, young expectant mothers, and they want to breastfeed, not a problem. They don't want to just breastfeed on demand, because babies will take advantage of that, and and you could increase their risk for early childhood caries doing that, eating too frequently. This study was kind of shocking to me. The results weren't shocking, but what the evidence demonstrated in this, they looked at children again. They looked at 393 children in the study. There were 257 that were caries free. They were average age of 5 years. They looked at them at 36 months, 48 months, and at 60 months later. And what they found is the children that had more milk associated with their meals and less sugar-sweetened cereal, breakfast cereal, had less decay. And what they found in the study is there's a significant percent of our population of children at this age that eat breakfast cereal for dinner. And I thought, really? But that's happening in our society. It's happening more than we probably want to admit. And you look at some of these cereals and they're 70% sugar. And so they're eating that 2-3 times a day. It's no wonder that we have the problem with obesity in our children at the moment, and type 2 diabetes, and also dental caries. This was an interesting study. It looked at erosion. And even sodas, even diet sodas, contribute to dental erosion. So also illicit drugs, abusive intake, and I got to tell you, one of the common patterns that I see with my high-risk caries patients is soda. More often than not, it's not diet soda, but it's soda in general. Mountain Dew. They tell you they drink 4 to 6 cans of Mountain Dew per day, which means they drink 12 or more, or they have 3 or 4 big gulps. And I tell patients, you can have a Mountain Dew, have one, but gulp it. Don't sip it, right? Drink it, get it down. Drink it with a meal. Rinse your mouth out with neutral water afterwards. Don't brush your teeth. So we have to change the paradigms on their behavior. So so we see those patients in our practice that are sipping this stuff all day long, and that's where it becomes a problem. I found this was a very interesting study. It was looking at Down syndrome patients, and I have a number of these in my practice. I'm sure that you have a few as well. Alan Wong has done some great research in the last couple of years looking at the Special Olympics, carie-free funded studies, help fund studies on special athletes at the Special Olympics for the last 3 Olympics, trying to get a handle on what does this disease look like in that population. What are their ATP, bacterial load levels? What are their risk factors? And Alan did a great study that was just published, and he sent me a copy of it. And it was interesting because what he found was that raisins turned out to reduce the ATP load, and these special athletes that were snacking on raisins actually had lower bacterial load than the ones that weren't. So we traditionally have thought of raisins as a bad, sticky, sugary food that we shouldn't eat. It may be that the antioxidants in the grape are actually having an effect on the biofilm. We don't know. But what we know clearly is it immediately reduces the bacterial load and the ATP score in the mouth. And most foods, when you do that, increase it. So it was a very interesting outcome. Now, in this study, they looked at 45 sibling pairs between the age of 6 and 18, comparing the child that has Down syndrome and their DMFT scores, looked at their risk factors, and what they found was they had a lower decay rate. And I have to tell you, my Down's kids in my practice have very low decay rates. And I mean, thank God for that, right? Because it's hard for them to come to the dentist and sit still and have their mouth cleaned and treated and whatever. Needles and drills would be even harder for them to manage. But one of the conclusions in the study that I found quite interesting is that they said it may be in spite of the fact that they have hyposalivation. And I have to tell you, every Down syndrome child that I have in my practice has so much saliva, you couldn't work on them if you wanted to. And it's like to say that they have hyposalivation, it's like that doesn't match my clinical experience with Down syndrome. So anyway, I just wanted to share that study with you. This was a very interesting study. It came out of Scotland. One of the challenges that we've had on home care and hygiene is that toothbrushing and flossing, particularly in children, hasn't demonstrated any net outcome. Toothbrushing and flossing, and these studies have been done over the last 40 years, haven't really improved DMFT scores. So while we think that patients should brush and floss, on children we don't have scientific evidence that says it actually improves anything. Those studies are few and far between. This is a long study. It was 20-some years. They looked at preschool children in Scotland. There were 99,000 children in this study. And they looked at them between age 2 and 3, and then they followed them they started to teach them how to brush in preschool. And then they followed them over a period of 12 years. And what they found was it reduced by teaching a child how to toothbrush in preschool between age 2 and 3, reduced their decay rate, their DMFT score, from 3 to 2 at age 12, which is significant. That's a 30% reduction just by teaching the child at a young age how to brush, not floss, just brush. And this was a study over a period of 20-some years, and it was 99,071 children. So it's a huge cohort. So I thought that was a very interesting study. So nursery toothbrushing is effective. This study looked at 620 adults, Caries Active, and they gave them xylitol. And this is actually the secondary analysis, the xylitol paper that Bader and Sugars did. On secondary analysis, they took the senior citizens that had root lesions, and the ones in that category that had root lesions had 40% decrease in decay rate by using those xylitol mints. So the xylitol mints 5 times a day reduced root surface lesions on senior patients that were in this study. So that tells you that it targeted. So if you've got a patient in that category, giving them mints is probably a targeted therapy for that person. So when the results came out and everybody said, oh, see, xylitol doesn't work, well, in secondary analysis in this study, looking at the data, it actually had a profound effect, 40% reduction in lesions on the senior citizens that had exposed root surfaces and they were high risk for decay. So xylitol does have an effect. It needs to be a targeted therapy. Everybody following me here? So it didn't have an effect on the whole group, but when you looked at people that had this risk, giving them the mints actually made a significant difference. Now, nobody then all the papers didn't come out and go, oh, we were wrong. No, they kind of like swept this one. Nobody wants to talk about that study. There are a couple more genetic studies. This one was published earlier this year, in fact in May, looking at single nucleotide polymorphisms and for amelogenin X. And that gene helps control and develop amelogenin, which is the protein scaffold for the development of enamel. Everybody following me there? And that gene, we assumed if you had poor development of enamel or if you had a defect or a polymorphism of the amelogenin X gene, that you would maybe be at higher risk for dental caries. Doesn't have an effect, is not playing a role. So isn't that interesting? So amelogenin X, no effect. Now this study, they looked at 1,004 participants, 14 to 56 years of age. Again, they looked at 1.2 million single nucleotide polymorphisms, and what they determined was there are different genes that affect different surfaces. What they found was a correlation between genes that affected pit and fissure surfaces, and there were different genes that seemed to correlate to smooth surface lesions. So this kind of follows up some of the work that they did earlier. This is again from Schaefer and Feingold. What they found was those correlations affected even if you just looked at pit and fissure versus smooth surfaces. Now this is where we throw a little sex in the show today here. We're good. I thought this was very interesting when I saw this study. 30% of the genome 30% of the DNA in a bacteria in a biofilm is not its own. 30% of the bacteria, of the DNA in a given bacteria is not its own. It comes from other members of the biofilm. They have bacterial sex, if you would, and they share DNA. 30%. So as we start talking about, now we go back to Lizzie Buchan, this is why this all comes back home for you. This should kind of complete the circle. We shouldn't be concerned about which bacteria are present. We need to be concerned about which genes are present because they're spreading them throughout the biofilm. Everybody okay with that? These bacteria, and they don't have to be of the same genus and species. Neisseria will share DNA with Rothia. I mean, they all share bacteria, right? Or they all share DNA, rather. So it's like 30% they estimate of all the DNA in a bacteria is from other bacteria, not its own. So we shouldn't worry about which bacteria are present anymore. It's not a matter of there's 50 species. We really need to worry about which genes are present. So these genes transfer through the cell walls. Scott, I'll take one more question, then I need to move on. If one bacteria in a biofilm is resistant to an antimicrobial agent, within 30 minutes, everyone in the biofilm is. If one bacteria in a biofilm is resistant to an antimicrobial agent, within 30 minutes, all of them are. That's how rapid they change this stuff up. That's why biofilms, 2/3 of the diseases now left that we're treating on mankind are biofilm diseases. They don't respond well. They don't respond to vaccines. There's not going to be a vaccine for dental caries. I mean, if what I've shared with you today doesn't convince you that a single vaccine is going to solve this, that's like ridiculous, right? There is not going to be a silver bullet. There isn't going to be a single magic pill or magic rinse that's going to eliminate this disease for every patient. It doesn't. These are biofilm diseases. It's going to take. It's a multifactorial complex disease. It's going to take a multifactorial approach that has to be targeted to the risk factors. Is everybody okay with me on that? And we have to think differently to make that happen. So I don't want to alarm you. I'm having great success managing this disease. I've got patients that were high risk that are disease-free 7 or 8 years running now. It can be done, but you have to ask why. Why do your teeth look like that? Find the risk factor, find the suspect, and then target your therapy for the suspect. That's the process that we have to take. This study, I'm just about done with the studies, and I'm going to just share a couple things, and we'll wrap up today. This looked at cheese, milk, and yogurt, and found that the pH in the kids that ate the cheese, they were 12 to 15-year-old children. The children that were snacking on cheese had a higher pH in their mouth for a longer period of time than milk and yogurt. So if you're going to snack on something and you're worried about that, cheese is a great snack. If you have a cholesterol problem, cheese not so great a snack, right? This also came out of our practice network-based research. This came out of the Pacific Northwest, and we were looking at, is there a correlation between different risk factors in senior citizens? And again, what they found is there's one surprising result, but what they found is that patients that had not enough saliva, had low resting pH of their saliva, over the age of 65 were more at risk for decay. Okay, we expected that. What I didn't expect is a description in the last line here in their conclusion, a thick, sticky, or frothy saliva. Thick, sticky, means that it really does. They don't have much saliva. Typically, the patients I see, they have a real thick, sticky saliva, don't have very much saliva. Was also associated with a decreased dental caries. I would have anticipated that would have been associated with as an increased risk for dental caries. So that was kind of an outcome I didn't expect. It was a fairly large cohort. So in this study, again, out of our practice-based research network, we looked at dental caries on root surface lesions on older adults and dry mouth. I mean, exactly the same kind of things that you would expect. Exposed roots, increased frequency of eating or drinking between meals. Nothing else really contributed to that. Fluoride in milk. This was interesting because fluoride in milk had a a great effect as a 0.05% fluoride rinse. And we don't fluoridate milk in the United States, but this is very popular in the Scandinavian countries. But what surprised me in this study is they used 5 parts per million fluoride in the milk. Now I got to tell you, that would form calcium fluoride, and calcium fluoride, by the way, is the bioavailable form of fluoride. It doesn't get into the enamel until it is calcium fluoride. That's how it attaches to the pellicle, and that is the bioavailable form. But 5.0 part per million of fluoride in the milk. I thought that was that alarmed me. This study looked at if you could have a child that wasn't exposed to mutant streptococci, as an adult they had a significantly reduced decay rate. So if we could control the infectivity of these bacteria in children, we're going to have a much better outcome for them as an adult. Again, I think that's something that we would expect. Now, I just had a dentist contact me this last week, and she asked me this question, and so I shared the study with her. It was very interesting. She asked this question. Is anybody here familiar with oil extraction? They're using coconut oil, and they put it in their mouth and they swish with it for 30 minutes. And she had a patient, a senior patient, that had come in. She had prepped 4 teeth, anterior teeth for crowns, and sent it to a ceramist that I use, a very good ceramist. But the ceramist, the delivery time is 4 to 6 weeks on those crowns. When she got her back and took the temporaries off, she had decay, significant decay she couldn't use the crowns underneath those all 4 temporaries. And she was concerned that the biomechanical risk that they may not even be salvageable. And she asked this patient, she said, this came out of the blue. I didn't know I said, well, what were her risk factors? Well, she went back, and I can't really identify any, but what the patient's been doing is oil extraction with coconut oil, and which has probably a lot of simple sugars in the coconut oil, I'm going to assume. But even in this one, what happened is, here they used safflower oil as a rinse, and it interfered with the protective mechanism of the pellicle. Just using safflower oil in the mouth, rinsing with for 10 minutes, it limited the ability of the pellicle and the biofilm to maintain a healthy pH, and reduced its resistance, the biofilm's resistance, the pellicle's resistance, significantly in just a 10-minute rinse. So I would tell you, beware of patients that are doing oil extraction. So I share that with you. This is safflower oil. The one that's popular right now in the U.S. is coconut oil. So let's talk about current. So that covers pretty much the scientific research. I gave you a little bit of everything, but I thought I went through these studies and had a hard time kicking any of them out because they were all kind of interesting to some degree. And I threw out the ones that I really didn't think had any clinical applicability, but I thought these were interesting. So here's some current issues. I've shared before ICDOS, International Cavity Diagnosis and Assessment System, which I think is ridiculous. I've told the people that worked on it, I think it's absolutely absurd. I can understand that it might be helpful to teach a dental student the progression of this disease and what it looks like, but if you expect me as a practitioner to sit down with a patient when right now I'm trying to determine whether I need to restore it or not, and now I have to grade it on a scale of 7 every occlusal fissure, are you going to do that? On 16 posterior teeth in every patient every day? Unless I'm being paid $100 a tooth, it ain't happening, right? I'm not going to do that. It's ridiculous. And it's overly complicated. We took what was simple and made it really complicated. And that's because these people are not practitioners. They need practitioners on some of these scientific committees. So I look at this, and what you realize is all of these treatments are the same, and all of these treatments are the same. So why do I need to stratify those 3 when the treatment's going to be the same, and the same for these 3? The only one I deal with is number 3. When I look at this, the increased risk, the treatment is the same. When I look at this, Everything to the left of the green is going to get a sealant. The scientific evidence is clear. Everything to the right of the red is going to get a restoration. There's no questions about that. The only one I don't know what to do with is number 3. I need one picture, right? Because right here is in the middle, and half of these people probably need a restoration, and half of them only need a sealant, and I got to determine which one's which. I don't need to worry about the 0, 1, 2. The 3s are where I struggle. This is the question mark, and I'm probably going to make that decision based on their risk. If they're at high caries risk and they have other lesions, I'm probably going to do a caries biopsy at least and attempt to do a restoration. If they are low risk, I'm going to look at that number 3 and go, I'm going to seal that. Everybody okay with that? I only need one picture. You can black out the rest. In fact, I should do that on that slide. Well, I got this from Doug. Dr. Doug Young at UOP. One of the challenges that we have right at the moment is we know that we can remineralize successfully interproximal lesions. And the question is, when do we remineralize and when do we restore? And it goes right back to the IC-DOS thing with the occlusal fissure. When do we do that? At what stage in this progress do I restore this tooth? And where do I remineralize? Well, everything to the right, when you've got a D2 lesion or deeper, everything to the right unquestionably gets a restoration. And this is where the paradigms, this is where the landscape is changing. Everything to the left, the scientific evidence is clear. We should be remineralizing these teeth. If they have an E2 lesion and maybe even an E2D1, maybe we should remineralize those based on making that decision based on the patient's risk. But we're going to remineralize these because that works. If you've got a patient that adheres to your program and you're coaching them and that's their goal, they can make that happen. I only need, again, one picture. I got to decide this one right here, this E2D1 lesion, do I restore it or can I remineralize it? And the scientific evidence is muddy on this in my mind. I mean, half of them probably need a restoration, half of them probably can be sealed, maybe 60% can be sealed. But how do you make that decision? Are you going to seal it or are you going to let it go? Because you and I as practitioners have the same problem. If you see this on your radiograph, you better either be remineralizing it or restoring it, not watching it. Right? Because that is failure to diagnose a lesion, and that is a problem, right? And if you restore all of these, you're probably restoring too many and you're over-treating people. So again, we're stuck in that same kind of situation. How do I make that decision? The best way you can document it and make it is based on the patient's risk. So again, if I've got a patient that's low risk, I'm going to attempt to remineralize that, give them a chance to fix it themselves, coach them through that process. And if they're high risk, I'm probably going to be more inclined to restore it based on what kind of response I get from them in our coaching sessions together. Everybody okay with that? So that's part of that language that Frosha talked about earlier. Now, this is the topic right now because you and I cut board lesions. My board lesion looked like that, right? And and it's still happening in some board exams. It's changing, but it's changing because they should not be restored. Not till they get for sure here and maybe somewhere in this range. So it's not black and white. What's the algorithm on that, Lee? I don't know, right? I mean, we don't have a diagnostic ability to say this one's cavitated. Here's the line, is if it's cavitated on the surface, you need to restore it. And if it's not cavitated, you have the opportunity to remineralize it. The problem is, I don't know whether it's cavitated or not. Now you could put orthodontic separators in there and you could take a polyvinyl siloxane impression like 10 days later and you could go through that. I don't have many patients that are going to allow me to do that, right? I mean, from a realistic sense. So I have to make that decision from a practical standpoint. But I wanted to bring this up because this is an important topic. And if you're restoring teeth currently that look like this, I'd encourage you to remineralize them. And don't watch anything. If you look at this and say watch, I want you to think remineralization. And of course, I'd love to have you think carie-free, but every time you say watch, think carie-free. That's my new motto. I had this patient was just in this last week, and I think you can appreciate on tooth number 4 that this is exactly the lesion. It's not, it's a solid. Oop, you have the opportunity to remineralize this. Let's talk about it. She was interested. Let's talk about that. So she started flossing. What she did was she started flossing, and she started using the CTX4 gel 5000 every day for a year. And when she came in to see me, I looked at her x-rays, looked in her mouth. I said, everything looks great. And she says, but what about the one that I worked on? I'm like, oh, yeah, that's right. Let's go look at that. And I looked at it, and I went, this works. Now, it doesn't work on every patient all the time, but it works. I can't begin to tell you how excited this lady was. I don't know how many people that she's going to go out and talk to about, but it's like she fixed that. Yes, Jonathan. Sometimes it doesn't. So if it doesn't progress, I'm not, I'm going to have them keep using that protective regimen, the protocol. But I've seen them reverse. I haven't seen them reverse all the way, but I've seen them reverse, Jonathan. So I had a number of patients that's happened to. We do one other development. If you're not aware of it, we do have new CDT codes for caries risk assessment with a finding of low risk. That's a D0601, D0602, caries risk assessment, and documentation using recognized assessment tools. That would be a caries risk assessment form. One that's been validated. The carie-free form that I use was validated in John Featherstone's study. We basically took his form and modified it. And then D0603, risk assessment documentation with the finding of high risk. I'll share this with you. The first dental insurance company that's going to be reimbursing for this has a plan. Every employee on the contract has coverage for this once a year. They're going to reimburse $50 to have the form filled out. So I think that's significant. Now, one of the last questions that I want to answer today, I have a lot of times, practitioners ask me, well, what do you do in your practice? How do you make this work? Well, basically, you got to have an accurate diagnosis to start with. And then we need effective caries management, predictable treatment outcomes. And that's how you get to there. We target the therapy. And I have to tell you, it's had the most impact on my practice of anything that I've done in the last 34 years. I use the carie-free caries risk assessment form. I know most of you are familiar with that. There's reasons why every question is on there has a reason, and where they're located and who fills it out has a reason. And then I use ATP bioluminescence, the carie screen test, as my biometric. And then I typically have simplified in my practice. I try to get the patient to use a kit, a 3-month. Whatever you're going to do for patients, give them 3 months worth of materials. If you're going to target their therapy, don't give them 1 month worth of material and make them come back in a month, because they won't come back. People today are busy, and they don't have the time to, I ran out of this rinse, I need to run back to my dentist's office and pick up another bottle. Give them enough to last for 3 months. So I typically use those kits, and that's how I use them. And I found that to be very successful. Last fall, Bob Bowers and I wrote a book on dental caries, what we know so far. We wrote this for dental practitioners and patients. I give it to patients a lot in my practice. I give them a copy and I have them go mark it up. Identify yourself here. If you see something we haven't talked about, tell me, because I need to know. I think there's probably a copy of it. If you don't have a copy of the book, there's a copy for everybody here. You can get that at the carie-free booth. We have now, I'm absolutely shocked by this. We have over 50,000 copies in print in circulation as we speak. I couldn't give you the latest number, but it's over 50,000, which is, I figured I would have the first 10,000 in a pallet in my garage, and my kids would have to figure out what to do with it someday. So there is a need for that. I'm going to leave you today with this thought. This is Mickey Ortiz, one of my close friends from Mexico. He's from Ensenada. And Mickey told me there are 2 words that will open many doors for you: push and pull. Thank you so much. I hope you enjoyed the presentation.